watching the recording, this is the pain learning series, and we're going to be talking about the autonomic nervous system and chronic pain. What's the link? Or not necessarily just chronic pain, but pain in general. But because you're watching the recording and I didn't come to the live session, you've missed the best bit, and we'll not tell you what it was. Okay, so I hope you can all see my slides still. Is that right? Yeah, that's fantastic. Great. So as I was saying before, we think about how we experience the world in terms of the five senses, the big five. So vision, hearing, smell, taste, and touch. So does anyone want to have a guess about how many senses we actually have? And hands up for who thinks it's just five. No, Becky says no, it's more than that. Yeah, and a lot of them, you know, we're sort of, if we think about how our brains are organized, then you know at least about a third of our brain is organized for vision, isn't it? That's such an important input, and you know we're so much paying attention to what we see in other people, and so on. And then another really large proportion is dedicated to touch and superficial sensation, especially things like the hands and the face and other important areas. And so so we do tend to concentrate on these parts of the way that we know what's going on. But in fact, there are quite a lot of other senses that are to do with what we might call interoception. So that's how we know what's going on inside ourselves. And you know, if we think about where pain is, it's something that we feel inside ourselves. So balance, really important. You know, if you've seen people with a history of falls or balance problems, then it really knocks their confidence, and they have a you know, it's really big fear of falling. Movement, you know, when movement is natural, as I'm sure as Becky has found with her dance therapy, when movement is natural and unconscious, it's easy. And when there's pain and the disturbance of movement, then it becomes really stiff and unnatural. Pressure and breathing. So when you're short of breath, that's a very unpleasant sensation, isn't it? Fatigue can be painful if you're really tired. Pain is a interoceptive sensation, itch, temperature, appetite, and when we need to go, our expulsion. So all of these are what we might think of as being embodied. And I'll come back to a really excellent book on this. You can find out a lot more at the end of the talk, which is called Embodied. So has anybody heard of the polyvagal theory? No, some nodding and some knowing. Yeah, that's grand. Sorry, I have to switch between the slides and whether I can see you or not. So the vagus is a really interesting nerve, and it's not really like any other kind of nerve in the body. So if we think about how it works, it starts off in your brain stem, the 10th cranial nerve, and the vagus meaning is vagabond or vague, and you can see it sort of spreading around all the structures in your throat and your mouth, and it's controlling your voice and your vocal cords. It's supplying the arch of the aorta and the heart and the lungs, and going down into the abdomen, supplying all the intestines and giving us interoception there, and also controlling secretions and digestion. So it's something that from this sort of nucleus up in the brainstem, it's spreading all through the body, really omnipresent in the way that we feel things inside ourselves. And the interesting thing about the vagus is that it's really attached to some other nerves that are involved with emotion and expression. So I always used to do an anesthetic list on a Monday where we would do, oh, let's see, I need to go back to the window. So this, does that sharing, did the slide disappear? Yeah, for you. Oh no, you've still got it. That's good. I'm getting a message from Teams that it stopped sharing. I used to do a anesthetic list where we would do pediatric squint surgery, and where you would be really nice to the kids and the parents, and you would get them anaesthetized, and then we would go into theatre, and the eye surgeon would start poking about at their eye muscles to make their eyes point in the right direction, and you'd pull on the eye muscle, and they would get a terrible bradycardia, so the heart rate would go down to nothing, no beats on the screen, and you would say, no, stop pulling, and you'd give them some atropine, and they would come back to life, luckily, all the time, 100%. But the interesting thing about that is the vagus that's mediating that response, and the afferent part of the reflex that causes that bradycardia. Anybody got an idea of where it's coming from, which nerve it's coming from? Nobody wants to risk it. It's coming from the trigeminal nerve, which is sensory for all of your face and your eyes as well. And so if we look at that diagram of the vagus, then there are different nuclei. So there's the nucleus ambiguous and nucleus solitarius, which is the ventral and dorsal nuclei of the vagus. And there's right beside it, there's the trigeminal nucleus, which starts off as the fifth cranial nerve, but then it has a tail that goes down to the cervical spinal cord, into I think C1, 2, and 3. And so it passes right next, and there's a big strong connection between the vagal nuclei and the trigeminal nucleus. And so the evolution of the vagal system and the polyvagal theory is that if we look at the way the vagus works in less evolved animals, or animals that have been around for longer and haven't carried on evolving to become sort of mammals and humans, so like reptiles, then the main function of the vagus is to cause immobilization if there's a threat. Then it's a bit like your kids when they're doing hide and seek, and they if they can't see you, then in their minds you can't see them. So the reptiles will do this. They'll stay incredibly still, and either the predator will think that they're dead, or they'll not notice them because they're not moving. It's feigning death. It's a shutdown, and you get bradycardia, and you also get this with things like the diving reflex. So if you look at whales and seals and other marine mammals that have been adapted to diving to really sort of incredibly deep dives, they slow their heart rate down to incredibly slow rates, and it reduces metabolism and oxygen demand, and they can stay under for a long time under the water. And so this is the oldest branch of the vagus nerve. It's the dorsal motor nucleus of the vagus, which is supplying the heart and the lungs and the guts, and giving us this bradycardia immobilization response. And the idea of the development of the autonomic nervous system is that the sympathetic nervous system is developed as balance to the parasympathetic nervous system, which is mainly coming from the vagus nerve. And it's to do with the opposite of immobilization. It's mobilization, it's fight or flight behavior, and it can increase metabolic activity and oxygen demand and cardiac output. So you generally don't want too much of that during an anesthetic, and it's very energy intensive and expensive for the organism, which is obviously useful if you're trying to escape from a predator. But if you're always running around and using your sympathetic nervous system, then you've got to find more food, spend more time on that, and perhaps that might lead to more danger and less chance of surviving in the survival of the fittest in evolution. So in mammals, the vagus has evolved to develop other functions as well as this sort of immobilization and the fight or and the sympathetic system balancing it with the fight or flight reaction. So it's become really involved with social communication and engagement, and that's where the connection between the vagus and the trigeminal nerve is really important. It ties into the facial nerve as well, which is to do with the muscles of and the movement of the face that are to do with expression. And obviously the vagus is controlling vocalization and is really important in the inner ear as well. So this is dependent on myelinated nerves rather than unmyelinated, and it originates in that anterior vagal nucleus, the nucleus ambiguus. So the myelinated vagus is fostering calm behavior and inhibiting the influence of the sympathetic nervous system. So there's a chap called Stephen Porges who's done a lot of work on this polyvagal theory, so the different functions of the vagus nerve, and mainly the anterior and posterior, anterior and dorsal vagal nuclei, and he's studied this in terms of perceiving safety or danger. And as we all know, we talk a lot about that in the theory of why people get persistent pain, why they develop central sensitization, is a lot to do with that perception of danger. How dangerous is it within the body and within the nervous system? So, as we said, the reptiles are default is to immobilize themselves when something dangerous is going on. But in mammals, that leads to a vasovagal response, and that can again be useful. You'll see that happening with mice or rabbits if they've been brought in by your cat, and they'll stay incredibly still, and you wouldn't notice them until they move. But sympathetic activation, the fight or flight, is more adaptive for survival. And then if we think about how we behave with each other, so there's a great illustration, I think, in Stephen Porges' book about how the evolution of the vagus for prosocial behavior is something that's especially developed in humans. So his way of terming it was that if you put a bunch of chimpanzees on a transatlantic flight from London to New York, then there'd probably only be one chimpanzee that would arrive alive, because they would have been all fighting with each other and trying to establish dominance, and there wouldn't have been any of the sort of vagal break on that aggressive sympathetic activity. So there's this sort of diagram which I was talking about, we were illustrating with the anatomical diagram of the vagus earlier on, that we've got our nucleus ambiguus and the dorsal motor nucleus interacting all over the place with cardiopulmonary system and digestive system, and going up into the attention system and other brain structures. So I'll maybe skip over some of these more complex things. So in social engagement, things that engage the vagus and give us that feeling of safety are making eye contact with each other, which is maybe a big problem with things like Microsoft Teams, where we're always tending to look at the pictures on the screen rather than as we're taught, look at the camera, which is a really difficult thing to do. And then you've got all your faces in the periphery of your vision, not on the fovea. And we vocalize with an appealing inflection and rhythm. We do the facial expressions that go with looking for approval or looking for agreement, get people nodding and doing things like that. And it's really interesting how the vagus can modulate the middle ear muscles to actually distinguish, like people talking from other background sounds. I have real problems with that. Anytime I go to somewhere where it's, I always used to hate going to discos when I was a teenager, because I could never hear what anybody was saying, and I would just be going, ha, and hoping that I was agreeing at the right place. So in vagal suppression, when there's the feeling of threat, then you see people's eyelids droop, the voice becomes flat and loses inflection, and people become less expressive, and their ability to concentrate on other people's voices becomes less acute, and people find it less easy to pick up social cues from other people as well. So there's all sorts of stuff that's going on throughout the nervous system. And in a lot of ways, I don't really like diagrams like this, because it's sort of labeling different bits of the nervous system as doing one thing or another. And I think that the interaction between all of them, as all these arrows show, is really the important things. But you can see things like fear coming out of leading to activity coming out of the hypothalamus and going down into the visceral organs and giving us our dry mouth and our queasiness in our stomach, mobilization and love, and it's in a way, I wish I'd left this slide out, because I don't remember exactly all the details of how this worked, but I'll point you to somewhere where you can find out a lot more detail about this, and we don't really have enough time to go into everything today as well. So when neuroception of danger is faulty, that's often what we're seeing in our patients who have chronic pain, but it's also a really common thing in people who have chronic anxiety or depression or other mental health problems, and you see it particularly in pain. When I've seen people with facial pain, and they always have that feeling of trying to shield the face. They always feel that things are coming at them. They've got problems with their balance, with concentrating on people. And you think about that interaction between the trigeminal nerve and the vagus, then all these sort of things sort of tend to start making more sense. And really interesting things that we find that anxiety and depression, then there's difficult with social behavior, but there's also a loss of heart rate variability. So we've got increased vagal tone, then we get an increase in sinus arrhythmia, and that's generally seen as the whole system working in balance. It reduces your blood pressure and reduces all the sort of activation sympathetic responses. And if you see people have been traumatized or have been maltreated or institutionalized, then you see that there's reduced heart rate variability in all of these people. And really interestingly, Stephen Porges did some really fascinating research in preterm babies who are in incubator getting painful stimuli all the time from the blood tests and the respiratory support and so on. And they also have reduced heart rate variability and increased sympathetic tone all the time. You see the skin is all mottled and the shut down because of the increased adrenaline circulating. So this is a video. Well, let's see if it works. I've remembered to switch on the sound. So this is a baby where mum is comforting the baby, but she startles him or her by mistake. Who thinks it's a girl baby and who thinks it's a boy? There's no commitment there. No comment. I'm not sure whether it's a girl or a boy. Isn't it interesting how you can't tell? So let's see if I can preview this video. I'm sorry about showing the slides in this way, but I just find this, it all seems...
Look at you.
So I'll just take that back to the beginning. So she's trying to engage with the baby, but she startles him or her instead.
Look at you.
You see that startle response and the delay, looking around, wide-eyed, crying. So lots of and the facial expression. So all sorts of things that are fired off by sympathetic nervous system, and so the vagus is really tied into into expressions of emotion. There may be 6 universal emotions, but we can pick these things up in people, and sometimes we can misunderstand them in different cultures. We can see people or in different contexts where we pick up things that aren't there and misunderstand people's communication. I think that's often an issue for people with chronic pain, where they can be flat and withdrawn and not engaging, and it's to do with the chronicity of their pain, continual activation of the sympathetic nervous system, and suppression of the vagal brake. So in my original talk, I had a really interesting study of how people interpret monkey expressions, and the repertoire of facial expressions is completely different from ours. And so people would be thinking that this was a study done out in, I think it was in Gibraltar, where people are regularly attacked by the Barbary apes. And it's because the people were interpreting their facial expression as being friendly when they were actually trying to warn the people off, because they were, they were feeling threatened and they were aggressive. So that's an aside. So this is looking at heart rate variability or sinus arrhythmia. So in people who have not had any abuse, then their heart rate variability had changed. People who have had a traumatic experience, exercise actually reduces their heart rate variability, and indicating suppression of the vagal brake and the increase in sympathetic activity. So if our vagus is dysregulated, then it can compromise all our internal organs like gut and heart and pancreas. So we get our, sort of feelings of palpitations and anxiety about breath, and we get our indigestion and irritable bowel syndrome and things like this. And it's really involved in modulation of pain and regulation of cytokines and the hypothalamus pituitary axis. So the brainstem areas are regulating this myelinated prosocial anterior vagal nucleus is our ventral vagal nucleus are providing output and feedback. So that's causing problems with the assessing and experiencing emotions. People can feel, so they're frozen and they can't or express emotions, or they become over emotional and break down when there's not anything terrible going on. So, and big connection between this neural function and immunological function as well. So we see this in people with borderline personality disorder as well, that looking at something upsetting, so this is people watching a film of an argument between mother and child, and then a neutral film, and then a conflict with a father and a child, and we see that the people with borderline personality disorder, they have decreasing heart rate variability as they and the heart period, so the heart rate goes up as they watch these things, and people who didn't have any of the traumatic experiences in the past, they have vagal regulation of the system. So gut feelings, neuroreception of danger can trigger vagal dysregulation. And I think really interestingly, over the last few years, we've been finding out more about the crosstalk between the microbiome, the bacteria in the gut, and the interaction between the bacterial transmitters that they release and the nervous system, which is mainly vagal input. So we get these gut feelings, and we feel like they are how we feel. But this is an experiment called the Love Bridge, which is one of those wacky psychology studies which may or may not be actually related to reality. So what they did was they had the subjects in the experiment walking over a bridge. And there was either a low-down bridge, or there was a high-up wobbly bridge they were walking over. And when they got to the other side of the bridge, there was a lady waiting to go in the other direction, but they weren't told to pay any particular attention to this woman. And after they'd finished walking over the bridge, they asked them some questions about how they felt, and then they asked how attractive did you find the lady who was at the other side of the bridge. And so the overall results were the people that were walking over the low and safe bridge found the women at the other side less attractive than those who were walking over the high and wobbly bridge. And the theory from the psychologists who were doing this experiment was that that sympathetic activation of walking over the higher bridge was giving us what we would associated with feelings of excitement or attraction, and that influenced our perception of the woman who was at the other side of the bridge. But of course, as we all know about psychology research, a lot of it has not been replicated, and we have to take everything with a bit of caution. So we can feel with chronic pain often forced to stay in an uncomfortable state, can feel anger. We can have wants, the things that we want to try and soothe the pain, and that could be food or medication or comforting or medical attention and so on. And one of the really important functions of the vagus is to help us be close to other people without fear. So if we think about being intimate with somebody, if we're giving somebody a hug, then that's potentially a very dangerous situation to be in. So if you think about the praying mantis, and the male praying mantis is coming to um, get to know the lady praying mantis, but she's going to bite off his head. So luckily that doesn't happen often with humans, but there's still that danger in being immobilized, and the vagus helps to calm us down, that vagal break. And often patients will say, I would love to do this, but my body won't let me. So there's that internal governor that is really involved with as well. So thinking about the vagus in terms of response to novelty and safety, mammals and reptiles are different. So if we look at mammals and there's something shiny or bright or interesting going on, then it will stimulate communication and moving away from the safety of the mother, and they will quickly rush back to safety if it turns out to be frightening or too exciting, whereas the reptiles will not go for the novel situation. They'll stay with the safety, and so it's really important in developing our state regulation. And things that help us feel more comfortable and change vagal function are all sorts of things that we experience as babies. So prosody, the musicality in language, where we've got this universal baby talk that everybody does with their babies, where they do a sing-song voice which really calms the baby down. Ingestion, obviously, and relaxation of the facial muscles, especially around the eyes. So if you've got your eyes screwed up, then you're thinking, what are they thinking? And the social engagement of the auditory system. So I think in the implications for treatment of trauma, we find that things that improve the vagal brake on the sympathetic nervous system and reduce the activation of the sympathetic nervous system, which is a lot to do with the interaction between perhaps the amygdala and the hippocampus, the area where fight and flight and lots of sympathetic activation and traumatic memories are all interlinked, and there's great big crossover with pain there. We can use things like, what stimulates the vagus? It's the social connection, it's the prosody, it's the eye contact, it's that feeling of safety. And what else is the vagus mainly involved in is breathing and your heartbeat. So if we can do breathing exercises, I often say to my patients, if we can think about how can we really concentrate on the breathing and activate all those vagal signals that are right next to the alarm center and calm the alarms down, then there's really good evidence coming out that we can make a big difference with pain. So I think the things we can do to normalize vagal function are thinking about breathing, movement. So I think things like dance and moving together is really, really important. There's some really interesting research, and I've forgotten the woman's name altogether. It'll come back to me. Kelly McGonigal has done a really interesting book about movement, rhythmical calming speech or chanting. So if you look at what all sorts of religions do around the world, they make long expiratory noises like om and chanting in Gregorian chants, or the catechism and things like that. All of these have got long expiratory noises which were activating breathing and the vagal supply to the vocal cords. Music, of course, is really good. Cold water swimming. I can't see everybody, but I'm guessing that Becky is jumping up and down there and enhancing safety. So the things that I thought of, I found really interesting from this is Christopher Eccleston's a psychologist in Bath. Um, it's funny because he used to work in London and Lance McCracken used to work in Bath, and I think they completely swapped sides so that Christopher Eccleston went to work in Bath and Lance McCracken went to work in London. I might be mistaken about that. But his book about embodiment is where I got quite a lot of the material from and these different senses, and it's really interesting to go through. So he's divided it very much into all those different senses like balance and sort of internal body sense that we have that I was talking about at the beginning. I would guess a lot of you would have read The Body Keeps the Score, which is a fantastic book by Bessel van der Kolk. And it's looking at how traumatic experiences, whether they're really horrible and terrible traumatic experiences, or whether the little things like, the loss of the safety of being held with the mother, the rejection by a social group, the feeling of disappointment or something, how all these things can be stored in the body and lead to post-traumatic trauma uh, 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 and often chronic pain as well. And then the polyvagal theory by Stephen Porges is really heavy going, as there's lots of really, really interesting stuff in terms of neurophysiology and the research that he's done. But also, I think you can find, particularly Stephen Porges and Bessel van der Kolk, you can find a load of really good YouTube videos which explain all their ideas and I think can help us to think about how we might be able to use some of these theories in the pain clinic. So as usual, I've gone on for too long, and as I've been rushing around this week like crazy, like even crazier than normal, all night, there was somebody who'd been in touch with me and sent me a case study, but I don't think they're here today. Does anybody want to put up their hand if they are that person? Because I can't remember who it was. I don't think they're here. But I'll maybe stop the recording of the meeting, and then if there's any sort of comments or questions, I thought that would be really interesting just to have a discussion about some of the ideas of the vagus and the sympathetic nervous system, and see whether there's any other perspectives on it that people might have come across.